So Nan, thank you so much for being here.
Thank you.
I think it's really important that the first responders have their questions answered from a psychiatrist, medical doctor such as yourself. So one of the questions that I get asked in my private practice often is, well, what are psychiatric medications? Can you start with what are they and how do they work?
It's a big question. There are many different classes of psychiatric medications, and I'm glad you asked that because some people think that all psychiatric medications are alike, and that's so far from the truth. There are many different categories, and the most common ones are the antidepressants. Those are very commonly prescribed for anxiety, depression, different anxiety disorders, post-traumatic stress disorder.
Right.
Benzodiazepines like Ativan, also called lorazepam, Xanax, also called alprazolam. Those are used frequently for anxiety disorders, insomnia, different situations like intensely acute grief, also post-traumatic stress disorder.
Okay.
They're very different medications, and there's many different categories. There's antipsychotics, mood stabilizers, different groups of medications that have multiple uses. For example, there are medications used for high blood pressure and pain management that are used for anxiety. So there's many different kinds, and psychiatric medications, I guess the strict definition would be to address any problem that we consider psychiatric: depression, anxiety, insomnia, severe mood swings, psychosis. But one thing to know is that there are medications that are used for different purposes, like I said, blood pressure and anxiety.
Right.
So it's a very broad question.
Okay. So where would medications fit in the context of therapy?
Yeah. It's a good question. There are many different ways to address a problem. Medications is one of them, and there are lots of different forms of talking therapies, which different therapists have different specialties in. In terms of how to think about trying a medication, it's a very individualized thing. Some people go into a doctor's office and they don't want to talk. They want a quick fix. Give me a pill, make this go away. And then for that person, I would start talking about medications right away. I work with a fair number of first responders that I see them, want nothing to do with medications. They tell me, I don't take pills, I don't want to get addicted, or they get really nervous about various different things, both real and imagined. And so I would approach them with saying, tell me what your problem is, and let's go through all the different ways that we can address that. It's a very individualized thing. The way that I like to present solutions to everybody, to first responders and everybody else, is to say, these are the different ways to approach a problem. What makes you feel the most comfortable? Doctors are consultants and they offer information, and then that person can decide how they want to address their particular problem.
Okay. So you might have a person who starts with medication and then tries talk therapy, or starts talk therapy and then tries medication, or starts both at the same time, for example?
Yeah, I usually, when someone comes to me and they need medication, in my opinion, I try to encourage them to do talk therapy. And again, everybody has their own level of comfort, but we do know that there are different kinds of talk therapies that can be very effective. So yes, I do try to encourage that. And then I speak with first responders who aren't sure yet that they want to take a medication. And so I will say to them, let's talk about what I would recommend. And some first responders tell me, I'm not ready to try a medicine yet. What are the different ways that I could approach it? What are the potential side effects? What are the risks and benefits? And then they go home and think about it. And then they can decide. So, so there are many different ways to approach the same problem. And really, people can pick and choose which way to attack a problem first.
Okay. So of course, a lot of the people that we work with, the police and fire and paramedics and dispatchers, they're mainly worried about, is this going to affect their job? Are they going to have to report this? Let's start with some of those job-related questions. Is this going to affect the job of a first responder if they take some type of psychiatric medication?
Yeah, so I imagine that what they're asking is this going to affect me in a negative way? And really the goal is to affect you in a positive way. You know, people are, first responders, as anybody who's watching this video knows, have the most amazing amount of stress that comes their way.
Sure, sure.
Most first responders that get to me have post-traumatic stress disorder, at least some of the symptoms, insomnia, anxiety, mood changes, feeling irritable. There are so many different symptoms that can happen.
Right.
And so what I tell people is, you know, actually the goal is to have this affect your job so you can do it better, so you can actually maybe like it again.
Right.
And so you can focus and go into work every morning not thinking, here I am again, I hope that nothing goes wrong, but to remember why you went into the profession in the first place. In terms of negative effects, it depends on the medication. People are most commonly worried that they're going to be seen as weak, somebody's going to find out, or that it's going to slow them down, make them sleepy, affect their driving ability. And you know, for this, you have to use common sense. As with any medication, when your doctor prescribes something, you say to them, hopefully your doctor knows that you're a cop or a firefighter.
Right.
You say, could this affect my job performance? And you find out. And for antidepressants, the answer is usually it's extremely unlikely that it's going to affect your performance. Sometimes people get a little bit of insomnia. Sometimes they get revved up a little bit, like they had too much coffee. Sometimes they get a little anxious. You can have other side effects like getting a stomach ache. So it could affect your job performance in a very mild way. The vast majority of people try an antidepressant, say to me, I don't feel any different for at least a little while. It takes some time to work. And so almost, I'd say 80% of people really don't have any side effects. In terms of other medications like benzodiazepines, Valium, Xanax, Ativan, that is going to affect your job performance. That's the one with the bottle that says, do not operate heavy machinery or drive.
Right.
And so, so that you can't take while you're working, although there is a role for that medication. I do want to refer people to, there's a website, the American College of Occupational and Environmental Medication, and what that, environmental medicine, and what that website delineates is the different categories of medications. And there is A, acceptable, T, temporary, S, shift, and R, restricted. And every medicine goes into one category. And the addictive medications that will sedate you are considered shift medications or restricted. So you can use it on your day off or if you're on leave and you're having a hard time. But there are many other medications that are acceptable or temporary. I do suggest to everybody when you're starting a new medication to do it on your day off, because if you get a stomach ache or you get a little dizzy or one of the unusual side effects, you don't want to be at the job when that happens.
So you mentioned a side effect of getting a little dizzy or having a stomach ache. I can imagine my first responders saying, well, I don't want to have a stomach ache forever. How long is this going to go on? What would you say?
So that's commonly with antidepressants, and the ones that are most commonly prescribed are called SSRIs, selective serotonin reuptake inhibitors. Prozac, Zoloft, also called fluoxetine, sertraline, Lexapro, there's a bunch of them. And what usually happens is we start at a very low dose to make sure that someone can tolerate it, and if they don't have any side effects, we go up to a therapeutic dose. Most people, like I said, have no side effects. If you have a little bit of a stomach ache, it usually goes away in a few days. If it doesn't, then that's the wrong medication for you. If you take a medication and you don't like it, you stop it. You know, people have this idea that I don't want to start a medication because I'll have to take it forever, which of course is not true. You can stop it any time you want to. Nobody controls your body and what you put in your mouth. So if you don't like it, you call your doctor, you say, hey doc, you know, my stomach's upset, and they say, good, you know, let's stop that, and I'm glad you called, and we'll try you on something else. Usually though, if it's a mild stomach ache, it goes away in 3 or 4 days, and then I never hear about it again.
Yeah, okay. So you mentioned psychiatric medications. Basically, how do they work? That is the $1 million question.
and I've been doing this almost 30 years, and the theories of how they work have changed.
Okay.
The answer is every psychiatric medication affects a chemical in our body that affects our brain. And we do know a lot about neurotransmitters at this time, and that's the name for the chemicals in our body that affect our brain. The common ones are serotonin, dopamine, norepinephrine. There's many more, and we don't know everything there is to know about the brain. What we do know is that these medications affect the receptors that modulate those chemicals in our body and help increase or decrease the amount that our brain sees. With some of the medications, like the SSRIs, what that does is it liberates serotonin that is otherwise stored in our nerves.
Okay.
So it's not actually making anything, it's helping the body access what is already there in a way that it wouldn't otherwise.
Okay.
What we do know with time is that we are learning more and more about the brain. We learn that there are many different kinds of serotonin receptors, many different kinds of dopamine receptors, and not everything is known. One of the things that we're still struggling to understand is why would a medication work for one person and not another?
Yes.
And that's still being studied. But more and more we are understanding what medications can do and how to fine-tune them for an individual.
So how long does it take for an antidepressant to work?
That's a great question. I often have people expect that it's going to take a day, and that's not the way it works, unfortunately.
Not a happy pill.
No, it's not a happy pill. And so there are some people for whom antidepressants will take a very short amount of time, 1, 2, 3 days. Much more commonly, it's 2 or 3 weeks, and it can take up to 2 or 3 months. That's the frustrating part. Most people don't want to wait that long to feel better. And what we generally do is we start off at a therapeutic dose, and we give it a respectable amount of time, depending on the level of patience with everybody involved, maybe 2 weeks, maybe 4 weeks.
Yeah.
And then if they're not feeling any response, then we will increase it, and then watch that for a few weeks.
Yeah.
Now that said, there are some people who just have to try 2 or 3 antidepressants before they really do get a good response. You can't predict. There are some tests coming out that will help predict that, but in general, people don't take that test, and so I can't just tell by looking at you what kind of antidepressant is going to work for you. And so we'll try something, give it 2 or 3 months, and then try something else. The exception to that is if I know that you have a first-degree blood relative that had a good response to medication, then that's the one I'm going to go with. And so if somebody is thinking about trying an antidepressant and they know that their sister or their mother had a good response, then they want to bring that information to their psychiatrist.
What if it worked with their wife? Or
yeah, they tend to think that that is a good predictor, but unless you're a blood relative, it's not a good predictor. Now, I will have people come into my office and say, that worked for my wife, I want to try that one. And if there's no reason not to, then sure, I can try that one. Or sometimes people say, yeah, I see this commercial and that's the one I want to try. And we know advertising does work. And if there's no reason, sure, let's try that one. The other thing to think about is what medication is your insurance going to cover? Most medications are covered by most insurances, but you want to check on that because there's no reason to spend lots of money when you don't have to.
So another common question I get from first responders is, well, if I take these medications, then how am I any different from these junkies I see on the street?
Yeah, so I get that a lot. It's one of the many questions that really has very little basis in rational thinking because, of course, probably you're nothing like that person, but of course we think in our society there's a tremendous stigma that's attached to psychiatric medications, and people put that together. If I take a psychiatric medication, that means I'm crazy, or that means I'm broken or defective. And if I don't take a psychiatric medication, then I'm fine. Actually, what I see is that if you don't take a psychiatric medication, then you're depressed or anxious or medicating yourself with alcohol, and you're not okay. Most people on the street are not medicated. They're crazy, and they're just not taking their medications. And the people on the street that look psychotic need antipsychotics, usually very high doses of antipsychotics. They probably have been prescribed them within the past several months and just stopped taking them. And it's very rare that a first responder would be prescribed that medication in that dose. And it's more the rule that what you need is an antidepressant, which is an extremely common medication in our society. One of the things that people don't know is who is taking medication. You know, in a given room at a party, you're going to have 25-30% of that room on something. And it's a very common thing in our society, for better or worse. But when you see someone who is crazy and you start to think about, I don't want to be like that person, you have to ask yourself, well, what do I want to be like? Do I want to be the way I am now? Or are there symptoms that are really affecting my job and that I really could use some help with? But all psychiatric medications are not alike, and certainly all psychiatric disorders are not alike. Now, that said, there are situations where I have worked with first responders who have become psychotic, and that is also not really that unusual. The stressors that these folks are exposed to are mind-blowing. You know, as we know, that these folks are on the edge of human existence. They see things in a very short period of time that nobody should have to see. And we are not programmed to be able to tolerate that stuff. And the system gets overwhelmed. The stress hormones that get released is overwhelming to the system. And you can have periods where you're really not okay. And even hearing voices, which can happen from severe depression, or becoming completely paranoid for various reasons, those things can respond to, you know, short amount of time of powerful medication, so you can get back on the job and feel okay about life.
Okay. A first responder might ask me, well, if I take medication, does that mean I'm broken, or does that mean my body's broken?
I don't think I would think of it in terms of broken. Usually when someone asks me that, they're struggling with post-traumatic stress disorder, and what they're experiencing is significant symptoms from being exposed to overwhelming stresses. And what we do know is that the stress hormones are supposed to go up and then go back down. And with folks who have the kind of exposure that most first responders have, their stress hormones never go back down. They're always kind of waiting for the next thing to happen, and it takes a toll on your body. What we know is that this doesn't have to do with your core humanity or your soul. This has to do with the chemicals that are really taking a toll on your body. And sometimes you need a chemical to kind of reset those chemicals that are out of whack to get you back on track. So I don't think of it as an individual defect. I see it as your body has been producing an extreme amount of stress hormones, and we need to kind of have a reboot, a reset to get you back on track.
Yeah. Another question that first responders have is, again, related to their job. Do I have to report these medications? Do I have to tell my department that I'm on these medications?
That's a great question. I get that one a lot. The official answer is every agency has their own policy. And if you can, I would suggest to review that. And then what I tell people is, you know, find out from your physician, is this something that can affect me on the job? And you will be required to report anything that you're taking while you're on the job that can affect your job. But if it doesn't affect your job, then generally you don't need to report it. I think that far and away, first responders would be very happy to not report things, but you definitely, you know, there are situations where you are overwhelmed and you need a break, and they can assign you some alternate duties. So there will be situations that you're taking a medication. If you're taking a benzodiazepine, your doctor will tell you, you know, no heavy machinery, that includes guns, or driving, and so it is good to report that. Antidepressants, you don't need to report it.
Okay. So my first responder might say to me, hey, if there's a shooting, or if there's a really bad fire, or a mistake was made, or somebody gets hurt, and I have to take a pee test, is this going to show up in my urine? Is this antidepressant going to show up in my urine? What would you say?
Yeah, when there are critical incidents or situations where people want to understand every little detail, you might be asked to give blood or give urine. And there are many different tests that can come up with blood or urine. And the drugs that people are going to be looking for are benzodiazepines, opiates, amphetamines, cocaine, alcohol. The antidepressants are not part of that battery. It's an extremely uncommon test. The only time I've heard of it is in a very specific postmortem evaluation because it's a very expensive, rare test to get. And people don't care about those medications in your blood because they don't affect your performance in the same way. So generally speaking, that is not what they're looking for in your blood or your urine.
Okay. So is there a difference then between a medication showing up in the blood or showing up in the urine? Is there any difference?
There's a different, usually we look for drugs of abuse in urine, and we can look for lots of other different things in the blood. That can be done in addition to looking for drugs of abuse. You can see a lot more by looking in the blood. The P tests we really just use for pregnancy and for looking for substances of abuse. Yeah.
Okay. So sometimes a first responder's concern would be, if I start taking this antidepressant, I know I'm depressed now, I'm going through this divorce and, there are budget cuts in the city. I could lose my job. It's hard for me to make the house payments. I am depressed. I am struggling. But if I start taking this antidepressant, am I going to get addicted to it? Am I going to have to take it forever?
Yeah, so first responders don't like being dependent on too many things. That's true.
Nope.
So the antidepressants are not addictive. There's a whole list of different ones, and they're not addictive. And what I will say is that they're not specifically addictive, but when you stop taking them, it's a good idea not to stop cold turkey. You can have some symptoms of feeling achy or feeling sick. So when you decrease a medication, it's always a good idea to do it with the guidance of a physician, as we all know. Yep. And usually they'll take you off it in a few days or even a few weeks. And some people need to go slower than others. But there's no withdrawal syndrome the same way you would expect somebody to withdraw from alcohol or from benzodiazepines or from an opiate. In terms of being dependent, I mean, it depends what you mean by that. Psychologically dependent, what people tell me is they feel better when they take that medication. What I suggest to people is you take the medication after you know that it's working. You stay on it really for at least a year, because if you go off it sooner than that, it's very likely that your symptoms will recur and you'll be back right to the spot you were at and you'll feel terrible again. People often start to feel better and then say, hey, I feel better, I'm going to stop the medication, without really putting together that they feel better because they're on the medication. And often what happens is people will just stop it and they feel worse again. It's best to do it under the guidance of a physician and to decrease it slowly. And then some people sometimes find, they were going through a hard time, they had a critical incident, there was something going on, they had a divorce, they go off the medication slowly and they feel fine. I think just as often people find, wow, I feel like crap, like I did before I went on this medication. And then you have the decision to make. You're not dependent in any new physiological way, but now you know I will feel good if I take the medication, and I'll feel lousy if I don't take it. And that's an individual decision. People make decisions for all sorts of reasons. So it's a personal choice. What I recommend to people is to weigh out all the pros and cons and make your decision. And many people don't have any side effects. They just have this idea that, wow, I'm a person who needs medications, and they don't like that idea, so they go off it. I'll tell you, I work with a lot of first responders who say, boy, am I glad I discovered these 1, 2, or 3 medications, because I'm sleeping, my wife likes me again, I actually can enjoy myself, my kids don't drive me crazy, and they say, I might need to go up or down on the medication here and there, but I'm not messing with it. So there are plenty of people who go on it, find that they feel much better, and really don't want to go off it.
The other thing I find when I work with first responders is it's taking the medication is one part of it, and once they feel better, they start doing things like what you just mentioned, spending time with their kids and enjoying that. And maybe going to talk to some peer supporters and just enjoying life. And then those behavioral habits start to happen again. And it's a combination of that. It's spending time with the kids, gives you energy to talk to the peer supporters because you're on the medication. And maybe in a year and a half, when you have been doing all those things and those have been working, then to wean off of the medication is an option, but only because you have all these other good things happening in your life.
Yeah, that's true. And like I said before, our experiences really do determine the neurotransmitters in our bodies. And, we do know that if you eat chocolate or if you're in love, your neurotransmitters are really affected. We do also know that we can affect our own neurotransmitters by, like exercise, things like that.
Right.
But there are many people who are so depleted in terms of their healthy chemicals that they don't even have the energy to do that.
Right.
There's also, I work with a lot of people who aren't prescribers, but who do psychotherapy, and they want their clients on medications because they can't even talk about the difficult issues because they're so depleted, so depressed, and they have no energy.
Right.
And people can get on medications just to have the energy to then get into the other therapies, to get exercising again, to get out in life. And you're right, it is a cycle. And often, once they're back in life and they're doing other therapies, then they're healthy enough to be off the medications.
Yes. So along with addiction, sometimes people might worry about building up a tolerance of a drug and needing more and more and more to get the same effect. How would you speak to that?
So that is a physiological phenomenon. There are times that if you take a medication, the number of receptors in your brain changes and you need more to have the same effect. The most common drugs that happens with are benzodiazepines, opiates, and alcohol. Alcohol is something we should talk about in a minute.
Yes.
In terms of antidepressants, there is a strange phenomenon that sometimes happens. People will be taking a medication, let's say people are on a nice therapeutic dose of Prozac at 20 milligrams, and then it stops working 4 to 6 months. People say, my symptoms are back. And then you increase it to 30 or 40 milligrams, and it starts working again. And people start to think, whoa, what's the matter with me? I need more medication. And actually what's happening is the body is just seeing that there's a medication there and it's building up proteins for reasons we don't understand that bind to that medication and render it inactive. So your body isn't seeing that active molecule of Prozac and it can't use it. It's just that the body is binding to it. So if we just add another 20 milligrams, then you once again have that active medication available for your body to respond to. So that does happen, and if you notice the effect is going down, you just call your doctor and say, this is what's happening, and they will usually bump it up. If you get to the maximum level of a medication and it's not safe to go above that, there are times that we do end up either adding an extra medication to boost the effect or to altogether switch to a new antidepressant. And that's not that uncommon. There are people who have a good effect to one medication and it doesn't last. But we have so many tools to work with that we're very happy to try other interventions.
Okay. So of course, some first responders are going to say, well, I just object to chemicals in any way, and they just cover up the problem. It doesn't change anything, and it's all chemical anyway. That's just not how to fix it. What would you say?
Yeah, I mean, I get a lot of first responders who just say, I don't take medications. That's just common in our society to begin with. And so I like to ask people, why? What are you worried about? And often people just don't know. They just don't like the idea of a pill. And I don't think of it as covering up a problem or, not really getting to the root of the problem. When you have a depression, when you have anxiety, when you have post-traumatic stress disorder, your neurotransmitters are off whack. And you'll hear doctors say, so if you're diabetic and you just don't produce enough insulin, is there something wacky or broken about you? No, there's something wrong with your pancreas. You need some insulin. And this is just, these are fabulous tools that we have out there, and there's no reason not to use them. I think people worry that their personalities are going to be changed. And there are situations where people will have an antidepressant or a mood stabilizer, and they do feel a little bit muted. They feel like they're not feeling their feelings as intensely. And for many people, that's the goal. It's everything is just in their face, and they can't turn off their thoughts, and they're overwhelmed. The memories just bombard them. These images that they don't want to think about are just keep coming at them. And it does feel good to be a little bit muted. And then often people will say, I don't have the intensity of feeling that I like to have in my life. And sometimes that's a reason to go off medications. What I do ask first responders is, do you drink alcohol? Do you smoke marijuana? Cops tend not to smoke marijuana, but alcohol is pretty common. It's huge. And cops often don't see alcohol as a drug. And what we do know is that it is a drug. It's a legal drug. It comes in many shapes and forms and is socially okay. And people medicate every symptom under the sun with alcohol because it's out of your system, and you can use it for managing anxiety. What I like to point out to them is that they are medicating themselves with alcohol, and that it's actually much more toxic than most of the substances that are that I'm recommending. Well, than all of the substances that I'm recommending. Often when people begin to understand how much they really are using alcohol as a medication, they're more open to trying something that's going to be safer and not have all the negative effects of alcohol. What I would also add is that people sometimes tell me, I feel like myself again. And that's how I know that a medication is working. People will say something to me like, I went out for a walk and I saw a beautiful flower, and I just don't remember the last time that happened. Or I came home and my kid ran to me and I picked them up and I was happy to see them. And people begin to experience joy in their life the way that they used to. So people say they feel like themselves again. And that really is just music to my ears, that the medications are working, which is really very nice.
And a really important question is, what about sexual side effects? If I'm thinking about taking an antidepressant, what's going to happen with my sex life?
Yeah, and that's an issue that a lot of people are concerned about. When first responders come to me and feel very depressed, really their sex life is often the last thing on their mind, that they haven't had sex in months and they want nothing to do with their partner. And then sometimes when folks have been on an antidepressant for a while, things are going really well. In general, they're not having side effects of stomach ache or headache. And sexual side effects are fairly common. Between 50 and 75% of people do have sexual side effects. And those side effects generally are a decrease in libido or a decrease in performance. Either they can't have an orgasm, or they just generally can't get a lot of enjoyment from having sex itself. And often that is when somebody will say, okay, I'm ready to stop that medication because it's really interfering with my intimacy with my partner. And that is one option to see if you can decrease the medication. There is one antidepressant, Wellbutrin, bupropion, and that is an antidepressant that doesn't have sexual side effects. And so what we can do is to try that one, although it does take some time to wean off one medication and to wait for the other one to have a therapeutic effect. What my first responders and my other patients have told me, and I don't recommend it, but I think it's worth bringing up with your doctor, is that there are some people who have discovered that if they stop their medication for a day or two, their sexual function can come back, and then they can restart their medication and have the effect of the antidepressant. Like I said, that's not recommended because every time you stop your medication, there's no guarantee it's going to work again. But it's something to discuss with your doctor, and if you're going to just stop the medication anyway, it's an option. There are also some reports, and I don't believe this is well studied, but that Viagra can be used for both men and women to enhance sexual performance. So that's another thing that you can talk about with your primary care physician.
What's the difference between getting a prescription for an antidepressant from your primary care physician and from a psychiatrist? What's the difference?
That's a good question. And most of the time people do get a prescription first off from their primary care doc. They go in, they say, I'm struggling with depression, or I just don't like to do anything anymore, and I'm not sleeping. Everybody's telling me that I'm really crabby, and I just kind of feel like, what's the point with lots of things? And their primary care doc will prescribe something.
Yeah.
I think many primary care docs, the ones that I have connections with, are comfortable trying an antidepressant, and they usually have had some drug rep come into their office, and they might even have some samples on hand. And if it works, great. They can continue to prescribe that and you're done. For people who have more serious depression or other symptoms, many primary care docs will say, this is not my field and you need to go see a psychiatrist. Or if the standard dose doesn't work, they're worried about going to higher doses. And so primary care doctors are really not trained specifically in psychiatry. And every primary care doc has their level of comfort, and they will make recommendations suggesting that you go see a psychiatrist. The primary care doctor is the person that people usually see first. A psychiatrist is a more specialized person and has a lot more information, a lot more knowledge about the nuances, about specific medications, how high you can go, how you can boost one medication with another. So it's really, if you don't get the help that you need from your primary care doc, that's when you go see your psychiatrist.
So Nan, if I see a psychiatrist, I get a prescription, I fill it, I take it for a while. Does that mean I could just follow up with my primary care doc after that?
Yeah, so a lot of people want to see a psychiatrist as short a number of appointments as possible for a number of reasons. Number one, you know your primary care doctor better, you're more comfortable with them. Also, some people want to see a psychiatrist that is not connected to their agency, so that they have complete anonymity and they're paying out of pocket, and it can get very expensive. So when you go see a psychiatrist, one question to ask is, can you make a recommendation? Tell me what you're thinking. Write a report or call my primary care doc, and then have that person pick up and continue the prescribing. And there's really no reason why that can't happen. I think that many psychiatrists are very happy to have that happen. And then you can just go back to the psychiatrist for a shorter appointment. The first appointment tends to be 60 to 90 or even 120 minutes, so we can get all the information. And then the shorter appointments sometimes don't have to be more than 10, 15 minutes. And it's fine to just get your refills from your primary care doc and then go see a psychiatrist when you have another problem, or when your symptoms come back, or when your primary care doc says, I'm not sure what to do with you right now. So yeah, absolutely.
Okay. So tell me about this book.
So this is a great book. It's called Counseling Cops, What Clinicians Need to Know. And although you can't be your own therapist, it will give a lot of information about how therapists understand the specific problems that occur with police. I think many of the issues are common with firefighters as well. And it's an easy book to get. I think I got my copy on Amazon, not to push anything. But it's a beautiful book, and it will give a lot of information and give a guideline so that people may understand things that they wouldn't otherwise understand. So I think it's a fabulous resource, and I think probably also family members would be very happy to get a hold of some information. So it's something that I think everybody should. Every first responder should get a hold of and read.
So nightmares is sometimes such a big thing, especially after a critical incident.
Yeah, it's a very common symptom in first responders. Sometimes the nightmares are specifically what happened, or sometimes it's just something else that's in general very scary. It can indicate that somebody is struggling from post-traumatic stress disorder, but it can be a symptom that really is separate from PTSD as well. And I always ask about that because there is a medication called prazosin or prazosin also known brand name of Minipress. Minipress. It's a medication that's used for high blood pressure, and it's specifically shown to help with nightmares. What I suggest to people is that they can even bring it up with their primary care doctor. What I do sometimes see is that the primary care doctor stops short of getting to a therapeutic dose. The recommended dose can be up to 16 milligrams, and sometimes people try 1 or 2 and say, I don't know why it's not working. So just you can go and ask your primary care doctor to look into increasing the dose, or you can, sometimes people can Google articles, bring them into their primary care doctor, and show them information that they don't otherwise know. So it's a great thing to know about, because even just for short term after a critical incident, if nightmares are interfering with your sleep, which will in turn really interfere with your functioning, it's something that can be addressed. It's not 100%, but it's definitely worth trying. It's a fairly safe medication.
Okay. And do you have to take it every day?
It works best if you take it every day. It's a cumulative effect that as you take it more and more, it will get in your system. Most of the time people don't have side effects because it is a medication for blood pressure. Sometimes people will have their blood pressure go down a little bit, which is often not a bad thing. Sometimes they can stop their blood pressure medication and just take the prazosin. It works best if you take it every day. Most people find that they do not want to mess with that. Once their nightmares are gone, they are sleeping and they're happy, and it feels almost like magic. It's one of the strange effects that a medication can have that feels really very soothing, and that people don't want to have stop.
Right. So as a psychologist, I get this question, and I know you do too. What's the difference between a psychologist and a psychiatrist?
Yeah, so the difference is that, as you know, a psychologist goes to grad school and gets a PhD or a PsyD, and a psychiatrist goes to medical school. I went to medical school, I have an MD, I'm a physician, and I can prescribe as long as I have a license in any state. And there are very few states where a psychologist can prescribe. So in general, people will go to a psychiatrist to get medications. Many psychiatrists also do therapy, but I think more commonly people will go to a social worker, or an MFT, or a psychologist for therapy.
Oftentimes, first responder, when we're talking about medication, they'll say, won't I be seen as weak if I take medication?
Yeah, and this is back to the issue of the stigma in our society. And once again, there's no scientific rational basis for this. This is simply the stigma attached to mental health. It has nothing to do with science. Really, what I have seen, it's the first responders who are really strong, who are willing to say, I need help. And they're willing to put themselves out there and ask for help. And these are the ones that tend to have obstacles, have really serious issues that come up, and they can work past them and work through them. And these are the people that tend to talk about their issues, be leaders for the other people in their agencies, have relationships that do survive the difficult times. So, in my mind, it's really the ones who have the strongest backbones and the greatest amount of strength internally, who are comfortable with saying, I need help, going to get that help, and addressing it. So I really see it as the opposite, that those who are weak say, I can't deal with it, I'm going to pretend it's not there, I'm going to drink until I ruin my life and poison my brain. So I really see it as the opposite, that people who can address their issues are the ones that are the strong ones in our society.
Sometimes a first responder might wonder, well, won't this just get better on its own? Won't it, if I just take some time, if I just give it some time, won't it just get better?
Yeah, I get that question a lot from first responders and everybody else as well. And sometimes people want to give it some time, or let me just fix it on my own. I'm going to exercise, I'm just going to talk to my friends. So that question comes in all forms. And the answer, and this has been studied, is it might get better with time. But first of all, it's going to take a lot longer. And it might not get better with time. What I really suggest for people to do is to go to a psychiatrist and talk about it. And what a psychiatrist can do is to say, if you're getting suicidal, it's time to do an intervention. If you're not functioning, you might want to try different things, but just to find out what the interventions are. That said, there are some things that people can do that is really common sense, and everybody knows this, but people really underestimate the effect. But getting good sleep, nutrition, and exercise, I mean, that stuff, which we kind of poo-poo, is actually really crucial to somebody being healthy. So what I would say is, if you're not ready to see a psychiatrist, that's fine. But if you're not sleeping well, I don't know how you're going to get better. Diet really makes a difference. You got to eat right. And drinking alcohol is going to make it worse. There's really no question.
Every time.
And some people really do get better from talking about it with friends, really going out there, using their peer support network, either that's officially established through their agencies or their friends or their buddies at work or out of work. Exercise is proven to make a big difference. So there's a couple first responders who I've talked to who just put themselves on a plan for biking, just going out on their bicycle, not their motorcycle, their bicycle, and to really get solid exercise, and that did help. So it might get better with time, and there are things you can do, but if you find yourself going downhill, then the longer it's getting worse and the longer it lingers, the less likely it is to get better on its own, and it's time to seek some real help.
Okay. Thank you so much, Nan. This has just been so helpful, so good for first responders to get this straight from the horse's mouth, to get all this stereotype substituted with science, and to get all this stigma substituted with some real information. So thank you so much for joining us.
Thank you, Anne. It's a pleasure.